let's dive into some of the data a little bit, because we have some choices now. We've been talking about metastatic castrate-sensitive disease. We've got some choices, and what we know we shouldn't do is ADT alone. I mean, that's pretty clear. There's an abundance of evidence now that ADT monotherapy is not the right answer. And even now, going back to the old charted data of ADT plus docetaxel has also been removed as a recommended therapy now in metastatic castrate-sensitive. So everything is really doublet and triplet therapies right now. So let's talk about our experience with that, and maybe talk about some of the trials that there are that have given us support to treatment intensify instead of just the monotherapy. So, Rob, you're the medical oncologist. This is
I think with the recent the pairing of ADT, I like to tell my patients, it's like deciding what wine to have with your steak. Each one of the ARPIs has its unique side effects, and so I think patient comorbidities play a very big role in deciding what to use. And the classic example is if you look at the Latitude data where they paired abiraterone with ADT, they had really good data on high-risk patients, but you had the cardiovascular and the metabolic side effects of the prednisone, the steroids, given with that. We know that apalutamide has a higher propensity for skin rashes, and xelutamide lowers seizure threshold, and so if patients have known brain mets or CNS disease, you probably want to stay away from that. More recently, the ARANOTE study put darolutamide on the map as first line, and as a medical oncologist, I really like that data because it allows us to segue into triple therapy as per Arasen's data with the addition of docetaxel. However, we also know that darolutamide does not really cross the blood-brain barrier that well, and so you have less neurocognitive issues and less fatigue. It also seems to play really well in the sandbox with docetaxel in terms of the pharmacokinetics. And so in my practice, all of those aspects are discussed with patients, and I will try to tailor the doublet therapy to the comorbidities and patient expectations as well.
Yeah, let's talk about that. I mean, when you almost kind of can do a sniff test when you walk in the room and you say, you're a doublet, you're a triplet. You almost know it in just a matter of seconds sometimes. But what are some of the clear factors that would steer you one way or the other to really treatment intensifying versus maybe backing off a little bit?
Well, I mean, one thing we consider is clearly the volume of disease. The other thing we think of are high-risk features. Say if the patient has a visceral metastatic disease. So those patients are clearly candidates. We should talk about triplet therapy. If it's a low-volume disease, or if patient cannot handle the chemotherapy, if the frailty index is high and so on, then we'll stick with the doublet therapy. That's a conversation. The other thing is, initially, we were wondering, whether we should save docetaxel for later stage of the disease and initially treat them with doublet therapy. But now in the later stage of disease, we have a variety of other options available, and we could even consider triplet therapy upfront. The other thing I tell the patients is in giving docetaxel on CRPC, it's an unlimited number of cycles as long as they can tolerate or disease progresses, whereas in the triplet therapy, it's single agent, 6 cycles only. So that's another benefit. So I think those are the kind of factors we discuss with the patient and then come up with an informed consensus.
So we look at, we don't really have head-to-head, we don't have any head-to-head prospective trials. These trials that were done, they were independently done. You have Titan with apalutamide, you have Arches with enzalutamide, you've got ARANOTE now with darolutamide, and of course some of the older trials with Latitude trial with abiraterone. But they're all independently done. You can't really make any comparisons just based on that. But if you just eyeball them, you would say that efficacy probably is pretty similar across the board. And I think, Rob, you alluded to, probably for a lot of your patients, it's really as much the side effect profile that really drives that decision making. I mean, Chris, you're shaking your head. I mean, how important is that side effect profile when you're making a decision with these patients?
Yeah, I think I think it's very important. I practice in a more community setting. I take care of a lot of patients who oftentimes just have one option when it comes to their doublet therapy or their APRI with respect to their insurance. if I'm fortunate enough to have a choice, then certainly we're looking at all those things that we've mentioned: age, frailty, volume of disease, comorbid conditions, CNS disease, history of seizures. Are you worried about, how steady are they? Are you worried about falls? So yeah, I think all of those things you keep in mind when you're trying to pick your APRI, if you're able to get a choice. I can say right now, some of them are still very much cost prohibitive, and I can tell you in my practice, I still have the majority of patients on abiraterone and prednisone because of that.
Yeah. Just to follow up on Scott, there's another reason that most of my patients, if possible, I start them on abiraterone and prednisone for one reason, because early on studies have shown that if you put patients on prednisone and if you have to switch to another NSA, then there's a 30% response rate. On the other hand, if you start them with NSA first and then you put them on hardly anybody responds. So it gives us that option of a second-line therapy. Of course, with prednisone, like Rob referred to, there are other side effects that we need to be concerned about, and then these patients also need to be monitored for liver function tests. So it's a little bit more labor intensive, but it gives us a choice. And again, because these things are evolving so rapidly now since these studies have come out, we have the apalutamide and darolutamide options, so that's something to consider too.
And so the endpoints in these trials typically look at radiographic progression-free survival and overall survival. And I think clinically, obviously those are both very important. Patients often will ask, if you put me on this drug, will I live longer? But that doesn't always mean that quality of life will be the best. So how does radiographic progression-free survival and overall survival, when you're explaining to patients that this drug may give you a benefit in one or both of those, how do you explain that to them, and how do you frame that for them to understand what that means?
I think radiographic progression-free survival is oftentimes an easy surrogate of overall survival, because we know that progression of disease is associated with earlier demise. It gives us this objective early, it's like using 3-year disease-free survival instead of the 5 years. You get an earlier insight into whether the disease is working or not. In prostate cancer, especially, where the disease can take one of two paths, it could be bone predominant or, God forbid, visceral disease. That is all factored into the patient's prognosis. And so I tell them it's an easy or an objective way of assessing disease response before we get too far into a treatment.
So let's talk a little bit now about moving into that next phase of metastatic castrate-resistant disease. And I like to think and explain to my patients, people don't die from metastatic castrate-sensitive disease. They die from metastatic castrate-resistant disease. And what happens is when they get into that next space, that lethal time clock really starts to tick. And even in the best of hands, we're talking about maybe 3 to 5 years. And there's some good data now that shows that many of these patients, up to half of these patients that move into metastatic castrate-resistant, only get first-line therapy, that they don't make it to second-line therapy. So we've got to be very, very good about what we're doing and offering patients best care. So it comes down to potentially sequencing. So we've got some options in that bucket now. And how do you fit all that in? We know what the orals are. There's limited orals. We've got radiopharmaceuticals, we've got IO therapy now, we've got combination therapy. So let's talk about when that patient moves into metastatic castrate-resistant disease, where do we go next?
Well, I use the variety of approvals and indications that are out there. For example, if the patient has minimally symptomatic disease, then initially we thought of low volume or even a large volume disease, then we think of cephalocyl-T as an option. And the other thing is, like you said, Scott, these patients are progressing, so we need to be smart about which drug we give them so that we can get as many lines of treatment as possible. So with cephalocyl-T, we can give it in 6 weeks. Nowadays, they've changed regimen. We can even give it on a weekly basis, get through it within 3 weeks. Similarly, if they have bone pain, then radium-223 is an option. That's an indication. Can be given for 6 months. And now with the P3 study, we had concerns about including radium-223 and abiraterone, but now we can do enzalutamide and radium-223. So you can get combinations. So it's constantly being vigilant, and the radiographic progression, if we see the progression, talk to the patient. There are better options available now so we try and get through these options as quickly as we can, because the time may be limited.